Yeah, next I call upon Dr. Deepti Ghia, who is a consultant dermatologist and vitiligo expert at Jaslok Hospital and Research Center at Mumbai. And she's clinically trained with Dr. Sanjeev Mulekar. Over to you, Dr. Ghia.
Thank you. With that talk by Dr. Verma, that was really interesting about a new molecule. Now, we are going to take this talk on case-based approach for difficult to treat vitiligo. So we're straight going into clinical practice from the topics that we've just discussed. At the outset, I would like to thank Dr. Davinder for this opportunity. And let's move. So with that, I'm just showing the consent of patients have been taken for this presentation because I'm just going to be showing cases. Some of my cases are medical management and some of my cases are surgical management. So let's move with that. This is my first case. A 45-year-old man who's working in the Gulf country, having more than 60% body surface area involved in vitiligo for the last 3 years, is unstable with new patches evolving gradually. So this is the extent for the lower extremities also. So the difficulties in this case was one, that it's unstable. Second, the patient lived in Gulf practically 8 months of the year, and also it's a widespread vitiligo. So with that, first thing was to stabilize and then get the repigmentation back. When he was investigated for instability, everything was within normal limits except some vitamin B12 deficiencies, which was corrected. And we started on a course of oral mini pulse because that is the gold standard to stabilize. And then with B12 supplementation, and after 1 month of therapy, narrowband UVB was started in a chamber. Within 2 months, the patient started repigmenting pretty well. In around 3 months, the oral mini pulse was stopped. But now came the challenge that he still had 20% repigmentation to go, and he needed to go back to work. So this was and the nearest phototherapy center was around 4 hours away. So how do we manage that? And this was done by giving him a hand, like a device with 4 lights, a panel, and he was trained to use this. So the schedule was that it was given 3 times a week. The panel was put on a flat surface and the fixed distance was told. With that, the initial dose was around 2 minutes, which was equivalent to 200 millijoules. And then this dose was increased by 30 seconds every time till he gets erythema, and that erythema was told to maintain. And once this stops turning pink, then again the time was increased by 30 seconds. So when he was standing, he was told to take in the front, then bottom, then back, and again backside bottom. So this is how his phototherapy was continued, and then he almost reached the, completely repigmented, and this patient is doing much better. So if you see the review of literature, the highlight vitiligo studies show that home phototherapy is equally effective as in-office phototherapy. Also, if a survey was done that we need to look at, training our residents to look at home phototherapy, and this will make it more effective. And these are, the things about home-based phototherapy. Let's move to the next case. A 38-year-old female who was having vitiligo since the last 6 months, and it was rapidly spreading. She was taking steroids weekly, oral betamethasone pulse, also taking narrowband UVB for stabilizing, but with little results. And there was a history of a halo nevus which was present since the past decade. So this is how the patient was getting new patches, and that is a small halo nevus which was seen on the back. So a rapid involvement of these extremities was seen. The challenge out here was again an unstable vitiligo, not responding to phototherapy, and presence of a halo nevi since many years. So a simple punch excision was done and the halo nevus was excised. And within a month of therapy, continuing the narrowband UVB, the patient started showing much better response and almost repigmented, and is still maintained even after 5 years of treatment. So treatment of halo nevi with medical line of treatment or excimer, dermabrasion or excision helps in vitiligo management. The study suggests that excision or treating an inciting lesion may be a way to control the vitiligo. However, there are some case reports which show that even after the removal, after initial improvement, there is still some depigmentation. So it's still a big enigmatic condition, but this could be tried for our patients who do have a halo nevi. Let's look at the case 3 of a pediatric vitiligo patient, 4-year-old girl with rapid development of multiple vitiligo patches, previously treated with topicals and homeopathy. On examination, there was a trichrome vitiligo present, which suggested active, unstable vitiligo, and all routine investigations were within normal limits. The challenge out here is, again, it's unstable, the pediatric age group, and the involvement of the face, which was associated with a very big stigma. So, considering the age and involvement of multiple patches and keeping safety in mind, we started her on phototherapy, narrowband UVB twice a week with topical tacrolimus, and she started responding quickly and stabilization was also seen. But 3 months down the therapy, she developed depigmentation patches on her scalp in spite of getting repigmentation on the rest of the body. So these patches were new, which were not there earlier. So considering the new lesions which started, a 6-week course of oral mini pulse was added and topical steroid solution was also added. And within 3 weeks of therapy, again the repigmentation and the phototherapy was in place, and the patient almost responded completely. Currently she is in full remission. It's been 2 years that she's been in remission, but a lot of counseling is needed with pediatric vitiligo patients for the caregivers too. And oral mini pulse therapy consists of giving morning intake of betamethasone, but there is no role of repeat steroid courses in pediatric vitiligo. So in case of using it as just as a stopgap solution to improve the active disease, it's okay. But if it's in spite of stopping it and again it's coming back, role of OMP continuously in pediatric patients is not recommended. It's only to halt the progression, and also combination with phototherapy really helps in repigmentation. With that, let's look at the case 4 of a 70-year-old female who had depigmented macules on the face, upper extremities, and in the genitals. But the genital area was associated with severe itching. So with this itching history there, depigmented patches and the age of the patient being 70, so a differential diagnosis of LSEA was also considered because vitiligo never itches. So, and then it was important to differentiate these two because how long to give the topical steroids. So when a biopsy was done, it suggested LSEA, that is lichen sclerosis et atropicus, because of hyalinization of the collagen and smudging of the interface. With the topical steroid, she started repigmenting. The other lesions also did repigment, but it's important whenever you see genital vitiligo to differentiate these two, because it can lead to discomfort and even morbidity, which is associated with LSEA, which is not seen with vitiligo, and it closely resembles other things like lichen simplex chronicus, extramammary pagettes, and it's increased risk of malignant transformation which is seen, and lifelong topical steroids would be needed in LSEA. So, and in combination with moisturizers, calcineurin inhibitors, and vitamin D analog. With that, let's move to the case 5. I've just taken this case because of a difficult to treat site, that is a lip vitiligo, which is a challenge when we do surgery. So it's a 24-year-old male with stable vitiligo and not improving with medical and phototherapy. So the difficulty, as I said, is the dermabrasion of and the dressing. So I'm just going to show short videos for the dermabrasion. So the most important role out here is that of my assistant, because when they give a good traction, that's when we can do a good dermabrasion, especially at the junction of the vermilion border, and and lip being very vascular, it bleeds much more than the other sites. So to do it just at the level of the, getting the pinpoint bleeding is important. So your role of the assistant is the key when we do lip vitiligo dermabrasion. So also, putting something in the mouth so it doesn't ooze inside and doing the edges clearly, that would help. So this is how a dermabrasion, after a few minutes then the oozing stops, so you know that the level of dermabrasion is okay. With that, I'm also going to show the dressing of the lip, which sometimes can be challenging. where the trick is to use smaller collagen sheets. I think that's been taught by Dr. Munish Paul, that do small collagen sheets, let's call pixelated ones. This one is a bigger one, but small collagen sheets in that area will help to keep the suspension in place too. And then using layered dressings on top would help. And the important thing out here is using the sling. So how we do is we use different layers, and once the layer is in place of paraffin gauze, then using simple micropore and sterile gauzes can lead to a simple clean dressing out there. Let's look at the last case of a 35-year-old dentist from Jordan, weighing 135 kilos, developed segmental vitiligo at the age of 22, not responding to any type of medical or phototherapy, and was planned for non-cultured epidermal cell suspension. The difficulty out here was widespread vitiligo, Caucasian skin type, and the variegated pigmentation. So whenever you have a fair-skinned individual, it's very important to use the Woods lamp. For us with colored skin patients, it's very easy, but when we have a Caucasian patient, it's important to demarcate these lesions, and also the dermabrasion of all the variegated lesions should be done. And when you have multiple areas, so this patient was operated 4 times because he didn't want to do it under GA, we had to do it under local. So every 5th day a surgery was done, and then that's how we completed a full hand with the chest area. So when you have like larger body surface areas, you can divide the surgery into different sessions, and it does give you good results. With that, I would like to thank my mentors, Dr. Hamzavi, Dr. Mulekar, who've been very instrumental in my journey in vitiligo, with Dr. Davinder and Dr. Somesh, and my guides who have helped me in this journey. Thank you.